Hello everyone, and thank you for joining us today for this important webinar on bowel cancer awareness. Our speaker today is Dr. Una Kennedy. Una graduated from Trinity College Dublin in 1995. She works as a GP in Dublin and a GP advisor to the National Cancer Control Programme. She works in the areas of cancer risk reduction and cancer early diagnosis. On this webinar, Una is going to talk about bowel cancer awareness, which includes how people can reduce their risk, recognise the signs and symptoms, and why it's important to find bowel cancer early. Just before I hand you over to Una, if you have any questions throughout the webinar, please feel free to drop your questions in the Q&A at the bottom of the screen. So you'll see the Q&A there. It's a box with a question mark in it down on the bottom on the right-hand side. And we'll address them during the Q&A session at the end of this session. Okay, Una, if you're ready, we'll get started. Thank you.
Great. Thanks very much, Lisa, and thanks very much, Aoife, for having me here today, and to everyone for attending. I'm really delighted to be here to speak about bowel cancer. It's an important cancer and an important topic. And as you know, bowel cancer is April is Bowel Cancer Awareness Month. And look, first things first, just to be clear about what we're talking about, I'm going to call it bowel cancer sometimes, and then I know I'm going to drift off and start calling it colorectal cancer, and they're pretty much the same thing. The two terms are interchangeable, but I think it's possibly something that can cause a bit of confusion. But look, it's all the one disease. So if you pass on to the next slide, so please, Aoife, thank you. So first of all, what is the bowel, or what is the colon? So there it is. That's where it sits, kind of in the lower half of the tummy, under the diaphragm. I suppose if you imagine it's below the belly button, that part of your tummy. And there's two bowels. There's the large one and the small one. And when we talk about bowel cancer, we typically talk about the large bowel. Next slide, please. So that's what we imagine the small bowel might look like. It's got kind of jumble of bowel in the very middle of our tummy. Next slide, please. And the large bowel is a somewhat shorter organ that goes in a loop from the right side of your tummy, just inside your right hip bone, up past your liver. It takes a turn under the diaphragm, back down again to the left-hand side and out to the rectum. And bowel cancer is a cancer that can occur in any part from beginning to end of the bowel. So the next slide, please. And again, this is where we start talking about the colon and colorectal cancer, because typically the colon is kind of the bowel from where your appendix would be on your right-hand side, all the way down as far almost as the back passage. And that area, the back passage where the stool comes from when you go to the toilet, that's called your rectum. So sometimes we use the umbrella term bowel cancer. Sometimes we use colorectal cancer. Sometimes if we know the cancer is definitely in the rectum, we call it rectal cancer all on its own, or if it's in the colon, we call it colon cancer all on its own. The terms are kind of interchangeable though. So the next slide, please. That's what the bowel is. The next slide, please, Aoife. Thank you. So that's what the bowel is. So what's cancer? What exactly is it, a cancer, and what happens when you get cancer? And this is kind of a simplified enough drawing of what happens when cancer develops. So if you imagine, as you're looking at the screen, that little circle on the far left, if you imagine that's a normal, healthy cell in your body. Now, the cells in our body replicate and reproduce all the time, and they have to, even if you're not growing anymore and you're a fully grown adult, your cells are still growing. So you imagine, for example, you cut your finger and you have to produce new skin cells to repair that cut in your finger. So the cells that are there start to replicate and reproduce to produce those new skin cells to repair that cut in your finger. And that sort of process is happening throughout all our bodies all the time. And this is how it happens. So that's your cell, that little circle on the far left. In it, you've got the little red stripe and the blue stripe, and those are your strands of DNA. We each have 2 strands in each cell. And the first thing that happens when your cell divides is that the DNA doubles up. And you can see there you have 2 strands of red DNA and 2 strands of pale blue DNA. So the DNA doubles up. And then the rest of the contents of the cell double up. So you've got double of everything in the cell. Then the cell itself divides, and then you have 2 what they call daughter cells. And they're called daughter cells because they're kind of able to go on and have more baby cells over time. And cancer happens when something goes wrong in that process. Something triggers the cell to start reproducing like mad. So it starts growing and growing and reproducing, and you have lots and lots and lots of cells, and they grow into a lump called a tumor. So the next slide, please. And you might think, well, if the cells are reproducing and they're growing like mad, is it such a bad thing? I mean, if you had liver cells reproducing. Is it bad to have more liver, or is it bad to have more lung? And unfortunately in cancer it is, because the problem with these cells is they're generally very primitive and they don't do their job properly. So you might have cells in a liver that just don't do the job a liver is meant to do. Not only that, then they invade and they destroy the surrounding healthy liver, for example. So they stop the normal healthy cells from doing their job. So they don't do any useful work themselves, and they stop the surrounding cells doing their job. And then sometimes they can start spreading to other areas through the blood and the lymphatic system, and that's called metastasizing. And if they go to other parts of the body, they then stop other parts of the body working as well. So you can see the trouble that it causes when that happens. And that's a kind of a run through of what cancer actually is and how it develops. So the next slide, please, Aoife. So let's look at the epidemiology of bowel cancer, and that's just the numbers around bowel cancer in Ireland at the moment. So the next slide, please, Aoife. So at the moment, we'd have about 2,560 bowel cancers in Ireland every year. And it's roughly 1,000 or so, 1,100 female, and the rest would be in males. We know that, unfortunately, the minority of those cases are diagnosed at an early stage. So just about 40% of bowel cancers are diagnosed stage 1 and 2. And we need to get that up. I mean, if you're diagnosed at an early stage, your chances of survival are so much higher. We know that 90% of bowel cancers are in people over the age of 50. And this is the same for most cancers. Generally speaking, it's a disease that's more likely as you get older. But you can't be complacent. 10%, that's 1 in 10 of all bowel cancers occur in people under the age of 50. And just because you're a younger person doesn't mean you can't get cancer. Of course you can. You're never too young, unfortunately. I suppose there's some good news here in survival, that 66% of people overall will survive for at least 5 years. And that's a 50% increase from when the National Cancer Registry started collecting these data. So the survival is improving all the time for bowel cancer. I think there's more good news if you look at the box on the far right of your screen. If you're diagnosed at stage 1, your chances of surviving 5 years are 97%. You're almost guaranteed that you'll survive 5 years. And unfortunately, though, if it drops to 14%, 5-year survival if you're diagnosed at stage 4. So again, it really kind of demonstrates just how important it is to get those early diagnosis numbers up as best we can. So the next slide, please, Aoife. So this again is from the National Cancer Registry, which is a great place to go for any data around cancer in Ireland. And you can see that overall, it is the 4th commonest cancer in the country. So prostate is the most common, breast is the next most common, then lung, and then colorectal cancer. So overall, the 4th most common. It's the 3rd most common in females and the 2nd most common in males. So if you pop it on the next slide, please. So this is just to give you a kind of a graphic representation of what that looks like. So you can see the most common cancer in men is prostate, but colorectal or bowel cancer makes up about 13% of all cancers in males in Ireland. Next slide, please. And again, it's a very similar picture for females. If you just substitute the word breast for prostate, you can see that breast is the most common cancer in females in Ireland, followed up by lung and followed up by colorectal cancer, that's bowel cancer, at number 3. But there's not much in it in 2nd place and 3rd place for females. Next slide, please. I suppose the good news is that the rates of cancer, bowel cancer, are falling in Ireland, declining over the years, over the decades, so falling by about 2.5% per year in males and slightly slower in females, about 0.3%. Now, the numbers of bowel cancer are probably going to go up because we have a larger population and we have an older population, but the number of cases per 100,000 people, that's your incident rate, that's actually falling. So again, there is some good news here. Next slide, please. Again, I suppose I'm emphasizing this point. The mortality rates are declining as well as the incidence rates. So while the rates of bowel cancer are falling, the survival is improving as well. So the mortality rate in males and females has declined over the last number of decades, and the survival has increased by 50% over the last number of decades. It's really good news. The next slide, please. And just to compare bowel cancer survival to other cancers. So These numbers are from the National Cancer Registry of Ireland, and they show your survival for each of the common 5 cancers if you're picked up at stage 1 compared to if you're picked up at stage 4. So the green boxes show your 5-year survival if you're picked up at stage 1 for these cancers, and the red boxes show your 5-year survival if you picked up at stage 4. And you can see the difference. I mean, you don't even need to look at the numbers too closely. You can see the differences straight away between 5-year survival between stage 1 and stage 4. So for melanoma and prostate, you've 100% 5-year survival if you're picked up on time. To be fair, for bowel and breast cancer, it's very close to 100% 5-year survival if you're picked up on time. Admittedly, it's not so great for lung, it's just 57%, but that's an awful lot better than if you're picked up at stage 4, where it's just 4%. So I always think, look, you look at this and straight away it jumps out at you. We've got to get people out of those red boxes, if we can at all, and into those green boxes, get people picked up as early as we possibly can. There's an awful lot to play for there. The next slide, please. So we look at the risk factors for bowel cancer, because there's a lot we can do to reduce our risk of bowel cancer. So next, thank you, Aoife. So when we talk about risk factors, we talk about them in terms of modifiable risk factors. So those are the things you can change. And the non-modifiable risk factors, those are the things you can't change. Now, again, we have to stress that you could have none of the risk factors for bowel cancer and you could still get bowel cancer. I think just being human and being alive is enough of a risk factor. But you can never be too young for cancer, and having no risk factors that you can identify doesn't mean that you can't get cancer. Anybody can, unfortunately. So modifiable would be the things that we can change, and we can change our weight, we can change how much alcohol we consume, we can change whether we smoke. Non-modifiable are the things we can't change. So we can't change our family history, we can't change our family, and you can't change your age. You know, you can't change the fact that you're getting older all the time. Again, there is some good news here. The World Health Organization would say that up to half of all bowel cancers are potentially preventable by modifying our lifestyle, by modifying and changing the things that we can. So there's great news there and great reasons to be hopeful. So the next slide, please. So we'll move on again. Thanks, Aoife. So what can you do to reduce your risk? And it's important to say, we talk about reducing your risk. It's not quite the same as preventing. You can't prevent every cancer. The best you can do is take steps to reduce your risk. You can still be unlucky, unfortunately. So in a summary, you'd have to say eating a healthy, balanced diet, being physically active, maintaining a healthy weight, limiting your alcohol intake. Don't smoke, absolutely don't smoke. And if you do smoke, try to quit. And very important, if you're in the age group, try and take part in bowel cancer screening. So the next slide, please, Lisa. Thank you. So healthy, balanced diet, what does that mean and what does it look like? Lots of fruit, lots of vegetables, switch to whole grain wherever you can, and lots of pulses. Those are pulse vegetables. Cut down on red meat where you can at all, and avoid processed meats. That's your sausages, bacon, chorizo, salami. So bump up the fruit and vegetables in your diet, bump up the whole grains and the whole meals, and cut down or cut out red meat and processed meats. Next slide, please, Aoife. It'll reduce your risk of bowel cancer and a whole lot of other cancers as well. Red meat, it's not so much that there's something wrong with red meat, it's actually the cooking that produces compounds that can damage the DNA. And you remember the first couple of slides where I showed you how the DNA strands in our cells separate and divide. At that point of separation, if the DNA is damaged, that's the trigger that can set off cancer. Some of the compounds produced by red meat can cause DNA damage. Processed meat is the same. It's the nitrates in the processed meat that you use to keep them fresh. They can be converted on cooking to compounds again that can damage DNA and can increase your risk of bowel cancer. So cut out red meat if you can, cut out processed meat if you can. The next slide, please. What don't you need to worry about? I mean, sugar doesn't feed cancer. It doesn't make cancer tumors grow. Now, sugar can make you put on weight, for example, and that can predispose you to cancer, but sugar itself does not give you cancer. You don't have to eat organic fruit and veg. It does not have to be expensive. Carrots, parsnips, cabbage, cheap stuff that you can get will do absolutely fine. You don't need to take supplements to prevent cancer, and superfoods don't necessarily prevent cancer any more than your regular fruit and vegetables. So there's no magic to this. Simply bumping up any old fruit and vegetable in your diet will do the job. It's very simple. Next slide, please. Now, being physically active, I mean, I think the picture of the two in their lycra running might just put you off a little bit. You don't have to go out for a run. It'd be great if you did, but you don't have to. It is important to move. Just be physically active. That will keep your weight down. It'll reduce inflammation, and reducing inflammation reduces the risk of damage to DNA. It keeps your hormone levels healthy, I should say. So again, we have them running there, but any physical activity will do. Anything is better than nothing. So simply getting up and moving. Now, what do the government guidelines say? So the people who know these things would say we should all be doing at least 150 minutes of moderate activity each week, or 75 minutes of vigorous activity. And that's everybody, every adult. Children do a little bit more. Now, when I say every adult, what's vigorous for you might be different to what's vigorous for me. And vigorous means an exercise where you cannot continue a conversation. You're just breathless enough that you couldn't be holding a relaxed conversation. So for some people, that means going out for a run. For some people, a brisk walk would do that. So it's whatever that is for you. And that applies to elderly people and people with disabilities. But how you measure a level of vigorous is how breathless it makes you feel. We should all be doing muscle strengthening as well for our balance as well. The next slide, please, Aoife. So healthy body weight. And I mean, I know I said at the beginning, this is something we can all do. It's a lot easier to say than to do, as everybody knows, but it is really important. And we do need to talk about this, and we all individually need to reflect on this. The National Cancer Registry would say that the commonest risk factor we all have, commonest modifiable risk factor in Ireland would be smoking. Smoking is the one thing that people do that they don't have to do and that they can change to reduce their risk of cancer. The second commonest modifiable risk factor would be overweight and obesity. And they reckon in Ireland that overweight and obesity would contribute to about 1,000 cancers every year in this country. So you know, you don't want to make anyone feel bad about themselves, but we do need to talk about this and we do need to acknowledge it. Weight increases inflammation. I mean, it used to be thought that that fat around the tummy, that it did nothing. It was inert and it just sat there and did nothing. Now they know that it produces inflammatory proteins that can, again, damage DNA and increase your risk of cancer. But being active, even if you never lost weight, being active will reduce your risk of cancer. If you can at all, try to keep your weight within a healthy range. And you'll do that through the things we mentioned already, through the diet, through the physical activity, getting enough sleep as well. It's a lot easier said than done, but it is important to at least make a try at it. Next slide, please. And the next big one is alcohol. So the next slide, please, Aoife. Okay, thank you. So alcohol increases the risk of at least 7 types of cancer, and that includes bowel cancer. Now, it does that in a number of ways. Alcohol itself can break down to a chemical called acetaldehyde, and acetaldehyde can damage DNA. And we're back to that thing again. It's the damaged DNA that can trigger cancer development. So the breakdown product of alcohol, acetaldehyde, can cause that damage. Alcohol consumption can impair your ability to absorb adequate nutrients, and that can you're missing out then on the nutrients that can help protect you from cancer. It increases the levels of some hormones in the body, such as estrogen, and they reckon in the NCRI that about 7% of breast cancers every year in Ireland would be caused by alcohol. That works out at about 200 cases of breast cancer every year. So in terms of bowel cancer, though, alcohol is a risk factor for bowel cancer. Now, this can be, I think, a little bit confusing because in Ireland we have what we call low-risk guidelines, or guidelines for low-risk alcohol consumption. And they would say, well, 14 units a week of alcohol for men and 11 units a week for women would be considered low risk. But it's important to be absolutely clear about this. Low risk is not no risk. And the fact of the matter is that while a low level of alcohol consumption is low risk, any amount of alcohol consumption increases your risk of cancer. And that's the fact of it. And this idea that a couple of drinks a week is okay, or you have a Mediterranean diet and they have a glass of wine every evening after their main meal, that's good for you, that's a myth. The truth is that every alcoholic drink is doing you harm. Now, what you do with that information is up to you. Some people will ignore it, some people will cut down, some people will cut it out. But at least I think people need to know that the only safe level of alcohol is no alcohol. And the low risk guidelines are just that. They're low risk, not no risk. So the next slide, please, Aoife. The next one is smoking. And again, tobacco smoke is full of chemicals that can cause cancer, including bowel cancer. In an ideal world, you wouldn't start smoking, but if you do smoke, please try to cut down. If you go on to quit.ie and follow the instructions there, they will bring you to smoking cessation counsellors in your area. And it's a really fantastic service. They will see you for smoking cessation counselling. They can offer you nicotine replacement therapy, and they will do all of that free of charge, even if you don't have a medical card. So if you do smoke and if you want to try to quit, it's well worth looking at quit.ie and getting help to quit. Next slide, please. Now, bowel cancer screening, a really important topic. So if you move on, thank you. So bowel screen is Ireland's bowel screening program. It's available to men and women. And in fact, it's the only screening program available to males in Ireland for cancer. It can prevent bowel cancer and it can detect bowel cancer early. It prevents bowel cancer because if they screen you for bowel cancer and if they find a polyp, they will remove the polyp. Most cancers of the bowel will begin in polyps. Polyps are little benign growths in the bowel. Over time, they can turn into cancer. But if they're found and removed, well, then they can't turn into cancer. So bowel screen can prevent cancer. Bowel screen is also very good at detecting cancer early. Now, what they do is they send you phone up, you register. You can see the number there, 1800 454555, or you can go online and register. Then they send you out the bowel screen kit. And in the bowel screen kit, they have the gloves, the instructions, they have a little thing for taking the sample of your bowel motion. You do it, you take the sample, you wrap it all up, send it off to them. If they find no blood in the sample, they get back to say, we found no blood, we'll see you in 2 years' time. If they do find blood, they'll invite you for a colonoscopy. And bowel screen, this slide is actually out of date already. On the 1st of April, bowel screen increased the screening age to 70. So it's now available to people between the ages of 59 and 70, and it's free. The next slide, please. It's a really good screening program. Now, if we start at the bottom of this slide, you can see that overall in Ireland, about 40% of bowel cancers are picked up at stage 1 or 2. In the bowel screen people, 60% of cancers are picked up at stage 1 and 2. And you may remember one of the earlier slides when I said if you're picked up at stage 1 in Ireland, your chances of survival are 97%. And bowel screen is really good at picking you up at an early stage. For some reason, the uptake of bowel screen isn't great. It's only about 46%, compared to breast check, where it's about 75%, and cervical check, it's about 75%. For some reason, bowel screen doesn't seem to grab people's imagination as much as the other screening programs, so the uptake isn't as good. So I'd urge you, if you are that age, or if you know anybody that age, encourage them to go for bowel screen. So the next slide, please. And as I said, those are the instructions. If you know anybody between the ages of 59 and 70, if you are that person between 59 and 70, please participate in bowel screen. Bowel cancer incidence is falling in older people, especially in Ireland, it is falling, but it does seem on a worldwide level that there is an increase in bowel cancer in younger people. That's people under the age of 50. Now, nobody knows why that is. They think it's down to our lifestyle, the sedentary lifestyle. We're not moving enough. They think it might be down to alcohol due to our diet nowadays. But the truth is, people don't know. But it's just to stress again, don't ever be complacent. Don't ever think I'm too young, I couldn't have bowel cancer. You could, unfortunately. Next slide, please. I just want to compare bowel screen and try to urge the males in the audience to please participate in bowel screen, because something you hear a lot about men is, oh, we don't have prostate cancer screening. Why don't we have prostate cancer screening? And the reason for there isn't prostate cancer screening is because nobody's been able to demonstrate conclusively that it works. But there's still work going on in that area, but we're just not there yet with prostate cancer screening. But just to compare, prostate cancer, we'd have 2.5 times or thereabouts the number of cases of bowel cancer in men, number of cases of prostate cancer compared to bowel cancer. Prostate cancer is much more common, but yet prostate cancer only kills about the same amount of men as bowel cancer. So comparatively, the mortality rate for bowel cancer is much higher than for prostate cancer. And we do have a screening test for bowel cancer. So I would urge you to please participate in bowel screen. Next slide, please. And again, as I just mentioned earlier, early onset, that's EO at the top of the screen, is there for early onset colorectal cancer. It's considered cancer of the bowel in people under the age of 50. It does appear to be increasing worldwide. And again, the reasons for that are not fully known, but just to be aware of that and just not to be complacent. Next slide, please. So non-modifiable risk factors, the things you can't change. You can't change your age. Most cancers are commoner as we get older, so you can't change the fact you're getting older. Having a family history of bowel cancer can increase your risk. And we talk particularly about the first-degree relatives. That's a parent, a sibling, or indeed a child if you have a young person in the family with bowel cancer. Some genetic variations can increase your risk, and sometimes your medical history can contribute. So a history of severe inflammatory bowel disease. Next slide, please. So the bowel cancer symptoms, what are they? What do you not want to see, or what do you want to keep an eye out for? So the first one would be a change in the bowel habit for more than 6 weeks. And typically you're looking for looser bowel motions, going more often, or indeed constipation. And that doesn't resolve. I mean, it's one thing if you were away somewhere very exotic and you ate something and it made you a bit sick. That's one thing. But this is diarrhea that goes on, that persists. The next one would be feeling like you need to pass a bowel motion even when your bowel is empty. And that's a thing called tenesmus. So you know the bowel's empty, you know you've just been to the toilet, and yet you feel like you need to go again. Unexplained bleeding from the back passage. And I think everybody would spot that one. But if you do have unexplained bleeding, it probably should get checked out. Next slide, please. Unexplained tummy pain or pain in your back passage. Unexplained lumps, bumps, or swelling in your tummy, and unexplained weight loss. So, you know, it's one thing if you're trying to lose weight to see the weight going down, but if you're not trying and weight is falling and you've no idea why, maybe get checked. The next slide, please. And then feeling very tired or feeling very breathless. And the reason here is that bowel cancer can lower your blood count, and having the low blood count, being anemic, that can make you sleepy, and it can also make you a little bit breathless. And if you have those symptoms, I mean, it is very scary. There's no doubt about that. And I think it's an awful land, you know, for example, if you started passing blood or coughing up blood or vomiting up blood, it is scary. But, you know, get over that moment, but then seek help as soon as possible. Like I said, the 5-year survival for stage 1 bowel cancer in Ireland now is 97%. For stage 4 bowel cancer, it's 14%. So we would hear in some of the research we have done, we would hear people saying, well, I wouldn't want to know if I had cancer. And I often think, no, you actually would want to know, and you want to know as soon as possible, and you want to get in and get it sorted. You don't want to have it, nobody wants to have it. But if you do, you really want to get on it as soon as you can. So the next slide, please. So what happens next? Like, what happens if you have symptoms that you're worried about? So you pop in to see somebody like me. And if there's a concern, I can send an electronic referral to the local endoscopy unit. So we have, most GPs are computerized nowadays. I can log on to HealthLink, click on the electronic referral form, fill it out on the spot, and they get it straight away. So that it doesn't get lost in the post or anything like that. In most cases, these referrals sent by the GPs are checked daily, at least daily, if not more often than that. and they are triaged based on urgency. So if it looks urgent, you will be seen more soon. It's worth pointing out here, mind you, that if time is going by and if you haven't got a call for your endoscopy, or if you think you've been forgotten about, and particularly if things change, it's worth getting back onto your GP again and saying, look, something's different. I mean, I came into you with such and such a symptom, but it's got worse, or now I've got something else as well. It's worth contacting your GP and saying that to them, because that might bump you up in terms of urgency. So you may end up having a colonoscopy. The colonoscopy is the camera into the bowel, where they literally look at the inside of the bowel. If they see a polyp or if they see a tumor, they'll take a biopsy of it and send it off to the lab. And then they contact you and take it from there in terms of treatment. But again, it's just important to say, if the symptoms worsen or if they change, that could change how you're being triaged. So that could change how urgent they feel you are. So get back to your GP, they can get back to the hospital. It's also worth saying that the bowel screen checks are every 2 years, but it is possible to develop a bowel cancer between the bowel screen checks. So if you get symptoms, don't sit there and think, well, I had my bowel screen test and that was negative, so I know I'm fine. It doesn't quite work like that, unfortunately. It is possible that you could get bowel cancer in between bowel screenings. So the next slide, please. And I think the prognosis is actually very good, particularly, as I say, if you're picked up early. Overall, the survival for 5 years is 66% in Ireland. So it's a reasonably good 5-year survival. That's all stages, all ages of people. Survival for stage 1 is 97%, but admittedly, yes, it drops to 14% at stage 4. So you really do want to get in quickly. So the survival is really good if you're picked up early. And overall, bowel cancer mortality is falling 2% per year in Ireland. And that's the chart. Even if you're not bothered with the numbers, you can see the decline there in the picture. And bowel cancer survival has increased from 50% a few decades ago to 66% overall in this country at the moment. And it's getting better all the time. So the next slide, please. So I suppose the take-home message is then, reduce your risk. I mean, know who you are. Are you getting enough exercise? Take a look at the diet and see what you can tweak in your diet. Can you remove something? Can you remove the fry up and increase the number of fruit and vegetables? Can you get out for a walk? Can you cut down on alcohol? And if you can, please do. Definitely participate in bowel screen if you're the right age, and if there's somebody close to you who is the right age to participate, please encourage them to participate in as well. Those are the ways to reduce your risk. But remember, it's not always possible to prevent every single cancer. So in the event that you do get bowel cancer, try to know the symptoms: the looser bowel motions, pain or swelling in the tummy, weight loss, tiredness, abdominal lumps or bumps. Anything that's different for you and that doesn't go away, please get it checked out. And if you think you have something, contact your GP. So the next slide, please. Now, we have loads of information and resources available on our website. They're at our website is hse.ie/cancer, but healthpromotion.ie is where you can actually get the copies of these things. So you can see all the know the signs posters, and there's the Find Bowel Cancer Early poster. You can get them, they'll print them off, they'll send them out to you free of charge, and there's other resources besides them. If anybody here is interested in further learning, we have a cancer risk reduction e-learning program on HSE Land. Like all the HSE Land programs, it's free of charge. It's 11 modules. They're each about 10 or 11 minutes in length. You can dip in and out when you want them, when you don't want them. And they're accredited for ICGP CPD credits. The next slide, please. And we also have an early diagnosis of cancer e-learning program on HSE Land as well. Again, that's 2 modules. Each one is about 30 minutes long, and that's acceptable for 1 external ICGP point. And that's me. Thank you very much. And if you have any questions, I'd be happy to see if I can do anything with them.
Thanks, Una. We have a good few questions come in, so I'm going to go through them for you now, if that's okay.
Yeah.
Okay, so the first one is, how can someone detect duodenal cancer, and can the colonoscopy detect this, or can that check the duodenum?
Yeah, the duodenum is part of the small bowel. So the colon is the large bowel. So the duodenum is part of the small bowel, and it's that part of the small bowel, say, not long after the stomach. So you have the stomach, and then it goes into the duodenum, small bowel, and then into the large bowel. So a colonoscopy can't detect cancer of the duodenum. They can do a duodenoscopy where they put a camera down the stomach into the duodenum and take a biopsy from the duodenum. And obviously, various scans will help that. So CTs, MRIs, or even a PET scan will help with that. But a colonoscopy, I wouldn't expect that a colonoscopy would do that at all. It couldn't. I don't see how it could, unfortunately.
So the next question is the 5-year survival the limit, or do people live a lot longer than 5 years?
Yeah, that's a really interesting question. Well, like as Lisa said, I qualified in 1995, and when I qualified back then, if you lived 5 years with cancer, you were doing well, and people were delighted. Nowadays, and 5 year survival was what everybody measured back then, because that's what you were aiming for. Try and get somebody to live that long with the diagnosis of cancer. Nowadays, that's kind of more of a convention. And because it's the way survival has been measured for so long, people continue to measure it that way, because if we keep measuring the same thing, we can compare and contrast progress over time, and we can compare with other countries and so forth, and with other cancers. So it's kind of a convention that you measure 5 year survival. But as I say, increasingly, no, people live longer than that. I had a lovely situation there a few weeks ago in the practice. I was going through somebody's chart. I was looking for something to do. I can't remember what I was looking for, but I do remember coming across a note in her chart, and this lady was diagnosed with melanoma skin cancer in 1985. She's fully 40 years since she was diagnosed. She's approaching 90 now, this lady, and I'm sure she'll make it to 90. But it just shows you how, in some respects, the idea of 5 year survival is kind of out of date, but it's a good measure. And it's a measure that we can compare this decade with last decade and the decade before that. And we can compare cancers and we can compare countries. So we still use it. But yeah, it is getting a little bit out of date, and that's a good thing.
If there is a family history of cancer, what age and how often should you look to get a colonoscopy done, and should you not wait for the 59 to 70 screening age?
Yeah. Okay. So I suppose the first thing is, and I know it's not really the question that was asked, but if you have symptoms, don't wait at all. So if you have symptoms, get seen straight away. I suppose I'm going to give you a kind of a non-answer there. It depends on the family history. Of more interest and of more relevance, I suppose, would be first degree relatives. Like I said, that's a parent, a sibling, or a child. I mean, you could have somebody aged, I'm going to say 54, who could have a 26-year-old child, for example, a grown-up child. So first degree relatives are particularly noteworthy, and the more you have of them, the more noteworthy it is. Some families will have particular syndromes, and there's a number of genetic syndromes that can increase your risk of colon cancer. So if you have a family history where you're thinking, you know, a lot of my relatives have had colon cancer, go to your GP and say that. They can refer you, if need be, for genetic testing to Our Lady's Hospital in Crumlin or to James's. And if you have a particular syndrome, they will follow you up and do surveillance depending on what you have. So it kind of depends on if they find a syndrome, and if they don't find a syndrome, what the degree of your family history have. I suppose in general, if you had to give very general terms, in general, people have colonoscopies, depending again, something like 3 years, 5 years. And in general, it depends then on the syndrome that you have. That's what determines how early you start. But I would say the first step is head off to your GP. Get the full family history, of course, if you can, because you know, you mightn't always hear of every cousin or every aunt and uncle. So get the family history as full as you can. Bring it to your GP, and then they can take it from there in terms of referring you to gastroenterology for surveillance or directly for genetic testing.
So the next one is there a plan to reduce the age for bowel screening in response to the trend of early onset?
Yes, there is, yeah. So in the charter for bowel screen, their intention is to lower it to 55 degrees, 55 years, and then raise it to 75 years. And they're in the process, you know, it used to be 60 to 69, now it's 59 to 70. So they're stretching it out all the time. And the intention is, as I said, to bring it down to 55 and up to 75. In terms of lowering it lower than that, there is some discussion about whether it should be lowered to 50 years of age, for example. And at the moment, that is with HICWA, as I understand it. And they are doing an assessment, an evidence-based assessment of that, looking at the evidence. When they're done with that, they will then make a recommendation about whether it should be lowered or whether it shouldn't. They'll present that recommendation to the National Screening Service, who will then consider whether to proceed. So I suppose there's work going on. This is a space that is kind of moving. It's a very living space, the age rates for bowel screen.
I do see a few people kind of had similar questions there around that. But one additional one would be, would it be possible to get a bowel screen test at 54, even if you had to pay privately?
I suppose I can't really say, because I can't speak to private companies. So I know that they're out there, and I would have to kind of bow out really at that stage. I can't say that I can recommend a particular company, and I can't say that I can recommend that you do it. So I know that they're there. I suppose that's the best that I can say. I know that they're there. I have to kind of bow out and just say, yeah.
And then we go with, I'll take two more questions. I can see because there's a lot of questions, which is great. Do you think you are at an increased risk of cancer if you suffer from long-term colitis?
Yeah, there is some evidence around that can increase your risk, but actually where it's particularly is in people who have extensive colitis, extensive inflammatory bowel disease from a young age, that sort of takes up affects a lot of the colon, and that is particularly severe. So that's where the greatest risk is. Outside of that, it's difficult to measure and difficult to quantify.
And then in terms of genetic predisposition, can you comment on Lynch syndrome prevalence in Ireland and the importance of family screening programs? Also, how long to access genetic testing?
Yeah, the Lynch syndrome is very interesting, and the prevalence in Ireland, it's actually very difficult to know. It's actually a very common syndrome, everybody thinks. I have seen different numbers in terms of its prevalence. I mean, I've seen 1 in 400, I've seen higher than that, I've seen lower than that. I think the problem is that we don't have a kind of a nationwide screening program to test people for Lynch syndrome. As I understand it, no country in the world has that, where everybody gets tested for Lynch syndrome. But and so for that reason, when you don't test everybody, it's very hard to get a feel for how common it is. But it's probably commoner than we know, or than we think. The importance of family screening programs, how to access genetic testing. Yeah, again, to access genetic testing, it's Children's Health Ireland, and it's James's Hospital in Dublin. I agree. I've just seen the comment there. It's unknown relative to the BRCA gene. I agree. I think it probably is. I think BRCA is more famous, but I think BRCA particularly predisposes you to breast cancer. And there just seems to be a lot more awareness around breast cancer, which is great to see the awareness. But yes, I just think the Lynch syndrome, the bowel cancers are possibly not as well known. But you can get tested for it, all right, yeah.
Right, we'll just go with the last question that's in there. Are the early signs of duodenal cancer the same as colon cancer, or are they slightly different?
Exactly, they're very similar. So you're looking at things like you would have symptoms, I suppose, higher up in the abdomen. So you would expect to have the weight loss that you can't explain and that you haven't planned. You might pass blood in the bowel motion, but because it's coming so high up, in the gastrointestinal tract. You'd expect the blood to be maybe slightly darker, not bright red, fresh bleeding. You might find a mass or a lump in the abdomen, again, relatively high up. I suppose you'd be thinking again around the belly button, that sort of area. You might get the crampy abdominal pain, and you might get acid reflux as well from a duodenal cancer. So slightly different. But again, you know, if you have any of them, you know, I wouldn't sit and wonder whether it's duodenal or bowel. Get them checked. If you have something that's unusual for you, get them checked. And most of the time people come in with symptoms, most of the time it's nothing, and it all gets sorted out and everybody's fine. But once in a while somebody comes in and yes, it does turn out to be a new onset cancer.
Great, thank you, Una. Just before I pass over to Lisa for our final comments, just to make another point around the modifiable risk factors. We do obviously have our staff stop smoking service for all staff working within the HSE. It is a free service for staff that you can access at any point. We have lots of staff stop smoking advisors who are available even just to chat about your smoking habits. You do not have to commit straight away to quit, but they're there and they are available and they are willing to support you on your journey. So if you are concerned at all and you are a smoker, you can always get in touch with us and we can point you in the right direction. So I will pass you now on to Lisa.
Thanks, Aoife. I just want to say thanks very much to Una for the very insightful webinar on bowel cancer awareness and for answering people's questions today. And thanks to Aoife for facilitating this talk under Staff Health and Wellbeing programme. I think we're going to finish up the webinar there now, but I just want to let people know that when the webinar closes, a little pop-up will come on your screen to fill in a feedback form, and we'd really appreciate it if you fill in the feedback form. So thanks again, Una, and thanks, Aoife.
Thank you very much, guys. Thank you.
Thank you, everyone.